All right, well, I guess I'll get it started. I'd like to thank Dr. Hosni for inviting me back to this meeting. It's my fourth year here, and it's really, I'm quite impressed with how it's come along. It's really fantastic faculty, and it's nice to participate. I have no financial disclosures related to this talk. I'll be discussing our experience at Weill Cornell with the treatment of thoracoabdominal aneurysms with our branched and fenestrated protocol. We know that the open repair of thoracoabdominal aneurysms has been evolving over the last 20 years or so, and large centers have, optimized their repairs, but really, despite all the best efforts, there's still a significant mortality associated with this, and not an insignificant rate of spinal cord ischemia, even in large modern series. We know with the infrarenal aorta that we can decrease the mortality and morbidity associated with the operation with conventional devices. And so the question is, can we extend those benefits to patients with thoracoabdominal aneurysms? There are a couple of classes of devices. There are some that are off the shelf that are designed to fit most patients, such as the Cook T branch, the Gore Tambi, the Jotec, which is available in Europe, and the Medtronic device. And then there are patient-specific custom designed devices off the Cook platform, and I'll be discussing our experience with both of these. Our physician-sponsored IDE uses both custom-made devices and the Cook T branch to assess the feasibility of endovascular repair in patients at high risk for open surgery. These are inclusion and exclusion criteria. I won't belabor them, just to say that we don't do this for ruptures. So if someone comes in symptomatic, we can enroll them in the trial. We are part of the United States Fenestrated Branch Research Consortium. There are 11 sites across the country, and we've pooled our data to allow for a more informative discussion of the results. Up until earlier this year, we've done a total of 101 patients. The majority have been men. The typical patient comorbidities you'd expect: older patients with cardiac disease, COPD, and renal insufficiency. The mean aneurysm diameter has been 68 millimeters. About 60% of our patients have had some form of prior aortic surgery, either open or endovascular, and about 60% of our patients are type 4 thoracoabdominals, and 40% are more extensive type 1 through 3. The key with these cases is to be meticulous about the planning. We do all our planning on the TeraRecon workstation. You get varying measurements, lengths, the location, and the clock position of the visceral vessels. This allows you to draw up a plan. We then submit our plan to the engineers, and the engineers at Cook will then come back to us, and there's a dialogue back and forth about what's feasible and what can be built. And ultimately, they send you this drawing which shows the lengths of the fenestrations or branches. I'll go quickly through the steps of the procedure. We use fusion extensively. It allows us to place markers on the patient. Then we get a CT on the table when the patient's under general anesthetic. And then we can use this to fuse to our preoperative CTA and place markers which allow for ease of cannulation of the visceral vessels. Our access, initially we would cut down, although we've gone towards percutaneous for all three accesses, but you want to establish a through wire, put a large sheath down from above to establish a stable platform to access the visceral vessels. And general principles, you want to limit pelvic ischemia, so put your devices up and take out the sheaths and just cinch them down and do your branches if you're doing branch cases, all to limit the risk of spinal cord ischemia. This is the 12 French Gore dry seal sheath flex going from above, and you can see how it tracks even in tortuous anatomy. And we like to park this above the visceral vessels and then work through that, leaving a buddy wire in place. And like I said, most of our accesses are now percutaneous. We've actually described our experience recently in, I think it was Annals of Surgery, one of my partners wrote it up. And this is just a typical case. This is a 4-vessel fenestrated case. This is not branch case, but we can work from either above or below. In this case, we got 3 vessels from above, 1 vessel from below. Get the sheets out, and this is what the reconstruction looks like at the end. And here's a recon. And then this is, at the end, we cinch down using Rommel techniques, and we can maintain wire access with a smaller sheath and restore flow to the legs while we're working. And again, this is all to decrease the risk of compartment syndrome. I'll speak quickly about spinal cord perfusion. We know about the collateral pathways to the spinal cord. There are certain principles we'll obey, so if we have extensive coverage, we'll stage it. And if we're really concerned about perfusion, we may maintain sac perfusion through a branch and have them come back at a later stage. We monitor our spinal cord by using NIRS, so we monitor the oxygen saturation in the paraspinous muscles because that reflects the cerebrospinal, the spinal perfusion. So we do selective CSF drainage, maintain the blood pressure above a mean of 90, and stage our procedures. In this case, we test occluded the celiac artery, and if there is no drop in the NIRS, we complete the repair. If there is a drop, we leave the branch open. Sometimes we'll put a bare stent to maintain the access. We've gone towards using our iliac branch as our test branch, and so that we simply have to come back and pass a limb transfemorally if we need to, if we see that there's a drop in the NIRS. I'll go quickly in terms of time. We wrote up our experience with the first 50 patients. We've had another 50 so far, but we wanted to look at the learning curve. About 60% were type 4s and 40% were type 1 through 3. We had a mix of both branch cases and fenestrated cases. We were more likely to use branch in the more extensive aortas. And we were able to get almost all the target visceral vessels in these patients with a 99.5% technical success rate. We noticed that our operative time decreased from the early to middle to late groups in the first 50. Our fluoro time, our contrast volume, and our blood loss in particular with improvements in the sheath all significantly decreased over the course of the first 50 patients. So this is despite being experienced with endovascular approaches, there's still a steep learning curve on this. These are the first 50 patients. We had an overall mortality of 6%. We've had one more patient die in the first 30 days, so we have an overall mortality of 4%. The new on-site dialysis was only in one patient. Our spinal cord ischemia rates, now we've had 3 patients out of 100, and so it's about 3%. We've had 2 strokes out of the 100. Our survival is at 2 years about 70%, and most of the comorbidity is related to the cardiac comorbidity. There are a high rate of secondary interventions in these patients. I'll go quickly, but most interventions were performed to treat endoleaks. This is the results from the consortium across the United States, and similar. They had a high rate of reintervention, probably at 2 years about 25%, but the vast majority were endovascular to treat endoleaks. And I will jump quickly. The only other thing to consider is that the branches that we're concerned about are the renal arteries, and so the patency of the celiac and SMA are pretty good, but the renal arteries are significantly worse than the celiac and the SMA, so you have to pay particular attention to the renal stents. And that may do with the geometry. There's a certain amount of angulation associated with the renal stents, and they're smaller vessels, and so we're meticulous about follow-up on our renal stents. And we think with some of the improvements in the covered stents that we use for the branches, particularly with the Viabon VBX stent, it's a little bit more conformable. We hope that the patency will be improved by that. So just in conclusion, thoracoabdominals remain a major challenge, both open and endovascular. We think that the early results with branched and fenestrated devices is very promising. Obviously, long-term follow-up is necessary, but I predict that the majority of these will be done in the future with an endovascular approach as surgeons become more facile with the technology. Thank you very much.